morning. Welcome to week 87 of COVID-19 Talk. I'm your moderator this morning, Morgan Ash with the Houston Health Department, filling in for Director Stephen Williams. Of course, we're joined by our local health authorities, Dr. David Purse with the City of Houston, Dr. Erica Brown with Harris County Public Health, and we have our great producers, David Castillo and Priscilla Key, and special thanks to Rotary Club of Houston past president Kathleen Finnegar. We have lots of questions this morning, so let's get right to it. The first one is this. The Texas Medical Center has restarted its COVID snapshot, now coming in your email boxes every Tuesday, reporting a lot of cases and a lot of hospitalizations. You know, what area of Texas does the Texas Medical Center snapshot represent?
So thank you for that, Morgan. Surrounding communities, which are typically linked by social and economic factors, are reported. And that includes Austin, Brazoria, Chambers, Fort Bend, Galveston, Harris. And of course, though, when you're looking specifically at the TMC snapshot, it is the surrounding areas from Houston, not from Harris County as a whole.
Thanks, Dr. Brown. Hey, Dr. Purse, wastewater on July 11th showed a 927% viral load compared with last week, and a 31% positivity rate. Should we run back in our COVID caves?
Yeah, yikes, right? So the numbers are going up. Interestingly, this rate of increase has been steady, whereas previously the rates of increase in wastewater viral load has been much steeper. So it's interesting how it's changed and that it's not as rapid an increase and dramatic an increase, but it's very, very steady, and that makes me think that there's momentum. So I'm afraid we're going to continue to see that, and our positivity rate's doing the same thing. So what we're not seeing is a parallel increase in hospitalizations. And so to the question, should we run back in our caves? I think we're at the point now where we need to learn how to live with this, but this doesn't mean that we forget about it. Remember, there are people who are getting hospitalized. There are people who are dying, and all of those hospitalizations or deaths are preventable. We still have a social responsibility to everybody else to get tested, isolate yourself when you're ill, and consider quarantining if you're going to be somebody who could be exposing a vulnerable person. So it's not time to just forget about this.
And of course, wearing those masks do a lot of good. Now, on the last program, you guys said that in general, home tests are pretty accurate when taken at the peak of infection. Two close family members of the person asking this question tested positive at-home tests, but when they went to the pharmacy and got a rapid test, it was negative. Are these home tests still picking up this brand new Omicron variant? And I'll add something to this. I have a stepdaughter at my house who has every symptom of COVID-19, but is on day 2 testing negative on an at-home test. What should we do? Go get a PCR?
So thank you for that, Morgan. Yes, we did talk last week about the accuracy of at-home tests. And I think the key is timing. So there's 2 pieces here. Number one, some of the at-home tests do evade some of the newer strains, the newer variants, but it's still worth getting the test. However, there are also, most of them are pretty good at picking up viral load once you really do have a high viral load and you're further along in your symptoms. So the key is timing of test. Okay, so to your question about your family member at home, the key is test again. So if you test today and the test is negative, test again tomorrow. Okay, and that goes for any of the at-home tests. Now, there are some at-home tests that have been found to be better than others, and you can certainly explore that on the CDC website, which will tell you which ones are better than others at picking up. But the gold standard also is still, to your question, a PCR test. But at-home tests do have value at the peak of symptoms, or if you just, to your point, that somebody has symptoms and you just feel like, we're just not getting the result yet, test again. And oftentimes the test will become positive because the viral load will be high enough to detect.
That's what I've been telling my husband, but I went ahead and made her an appointment for a PCR test this morning because when, I had COVID a couple weeks ago and it was like day 3 before I tested positive at an at-home test. So keep testing is great advice. Well, cases are on the rise in Europe. Are we still thinking that we're about 2 weeks behind that kind of a surge? And what does that tell us about the future here in the U.S.?
Yeah, so if you look at the cases in Europe, they are still on the rise in many countries. Now, I believe in the UK and in Germany, or I'm sorry, and in France, it looks like they may have peaked, but there may be, it looks like they just peaked. So that may just be a data lag, so we have to be careful about that. And yeah, we have trailed behind Europe by a couple of weeks historically, and New York City as well. And so, it's hard to know for sure, but clearly our numbers are going up at a very steady rate. Our crystal balls are not very good, but I would anticipate for the next several weeks, we're probably going to continue to see a rise. And then the other thing I just want to add on to the previous question, if you've got symptoms of a viral illness and you're testing negative, perhaps it's not COVID, but it's something that you can spread to somebody else. So let's not forget that.
So next coming up is we're going to be talking about an article, and there's several statements from this article that you guys are going to let us know if they're kind of myth or fact or maybe somewhere in between. So the article comes from the Tyee, and it's called "Get Ready for the Forever Plague: Public Health Officials COVID-19 Complacency," long title, has opened the door to new illnesses and devastating long-term damage. This has caused quite a debate. So let me know what you guys think about the following statements. It is now possible to be reinfected with one of Omicron's variants every 2 to 3 weeks.
So yes, there have been a few studies that have shown it's possible to get infected with another variant, and even a few cases of an Omicron subvariant. But again, this is an area that more study needs to be done. And unfortunately, it's all retrospective study, right? So we really don't have a final answer on it, but we do know that it is possible to be reinfected with a COVID variant.
Dr. Peirce, what do you think?
Well, I think, Dr. Brown is exactly right. I think every 2 to 3 weeks is a little aggressive in this quote or in the question. But to be reinfected with the next wave, remember, we get another wave because the variant, because we have a new variant and the virus substantially changed enough that it can spread around the community again. So which means, yeah, you could get infected with whatever the next wave is. So again, another reason to not drop our guard and recognize this ain't over.
All right, thanks, Dr. Peirce. Second statement from this article: even mild COVID can increase the risk of heart problems or lasting damage to airways. That's kind of scary.
So we know that long COVID can cause myocarditis or pericarditis, which is damage to the heart. But again, this is an area that we're not quite clear on all of the long-term lasting effects of COVID. But we do know that there can be lasting damage for quite some time. So I would say, if we're going on a tour, is that true or false? Yes, that is true.
And I would only add that every time somebody becomes infected, in terms of long COVID, you're rolling the dice again. So, just because you got sick with COVID one time, you didn't get any long COVID symptoms, that really doesn't mean that you're not at risk for it the next time you get infected.
The next statement is, the best way to produce long-term outcomes is to, quote, speed the spread of Omicron. Huh? What does that even mean?
So I'm going to take a guess at what I think it means. Something we touched on last time. I think we're trying to discuss herd immunity. So at this point, it's going to be hard for us to achieve herd immunity in the traditional ways because we've already seen so many subvariants. So I would say this one is false. It's not the best way to speed up. Is to speed up the spread of Omicron. In fact, as Dr. Peirce said, the more you can do to protect yourself against the variants, the better for you and for the community.
So, I understand the logic of this, and this kind of goes back to the 1960s, I guess, when they talked about kids having measles parties and stuff, and chickenpox parties and induced immunity. But there's a flaw in this thinking, and part of it is that if you become infected with whatever variant, if there's another variant that comes along, we go back to square one, we start all over again. And variants are coming from people who get infected and have complicated medical problems, we believe, such that they like harbor it for longer periods of time, giving their body an opportunity to make the next variant. So if we were to use this theory and get everybody infected as quick as possible, that would then include those people who are most likely to create the next variant and put us back to square one again. So what we really need to do is we need to stop it in its tracks today to the best of our ability. Otherwise, we're almost guaranteeing we're going to get ourselves yet another variant and cause this to start all over again.
Righty. Well, I'm going to skip the next two statements and kind of do something a little different. And that is, I think all of us got an alert this morning or yesterday afternoon that Novavax COVID-19 vaccine is now recommended for use in adults ages 18 and over. And that's according to the CDC. What do we think about it?
So Novavax, just to talk a little bit about it, is a little bit different type of vaccine. For those who are concerned about an mRNA vaccine and have had some hesitancy, I think it's a good option. I did see just skipping around a little bit, there's some question about it being used as a booster. We don't have good data yet about Novavax being used as a booster, but if anyone is still hesitant about getting vaccinated, this may potentially be an option for you because it is not an mRNA vaccine. It's a protein that is similar to the spike protein, which will induce enough immune response similar to those of mRNA vaccines. But again, it's not an mRNA vaccine. So it's a good option for those who have perhaps been hesitant, and hopefully we can get more people vaccinated.
And that is the mission every single day. All right, the next question I'm going to ask is something that I want to know, and I think a lot of us do. Why is 50 years of age the cutoff for getting that next booster? It's been 6, 7, 8 months since we've gotten our last one.
So that is a recommended. So if you are 50 and or younger than 50, 49 and younger, and you want to get a fourth shot, a second booster, there's no rule that says that you can't. It's the reverse. Is if you're 50 and over, they're recommending that you seriously consider getting the fourth shot, second booster. So and why 50? 10 years ago I would have been offended by that, but there is. Because we usually think of people 65 and over. Now wait a minute, now it's 50. Yeah, I can't vouch for why they picked 50 as opposed to 60 or 65.
Okay, if B1 is gone and the current vaccine is doing nothing for the current strain, well, according to this person asking the question, shouldn't we be putting all this booster talk on the back burner?
So this is really a complicated question, and I think the simple answer to a very complicated question is no. The key is that the vaccines do not they may lessen a little bit in efficacy for the variants, but there's still some value in getting vaccinated because you still get some immune boost. Okay, so that's the key. And then as we add on with the boosters and then longer term, perhaps with the bivalent, that will again give you an immune boost and give you more protection. The key is to get as much protection as we can as we go through these waves of changes and subvariants. So yes, the newer variants may be a little bit elusive to the vaccines that we currently have, but there is some value because there is some efficacy with even the vaccines that we have. And it's already been shown that again, I want to be clear that the goal has never been to not get COVID with the vaccines. The goal has been to prevent severe illness and death. And the data is clearly showing that we're doing that. Even with hospitalizations rising a little bit, definitely with infections rising, we're not seeing as much severe illness, meaning ICU admissions and death, as we had previously seen. So there's definitely value in continuing to get vaccinated.
All of that is good news, and we want to see a lot more of that. So keep getting those boosters when you're ready for them. All right, so the next question is, can I get Paxlovid to carry around when I travel, or is a prescription needed? And I think whenever I hear the word Paxlovid, I'm thinking about that, what's called the when it comes back, the rebound effect. Is that still a thing?
So it is still a thing. Personally, I think that the rebound commentary is a little bit overblown, because there are people who get COVID, they have mild symptoms, they don't get treated with Paxlovid, and then 5-6 days later their symptoms get bad. And so had they been on Paxlovid, they would have said, "Oh, I rebounded." And it's just that the timing of when their symptoms got worse. So I personally think there's a little bit of over attention to that. On the other hand, for the folks who did get Paxlovid, their symptoms abated, and then when they stopped taking it, they came back. Yeah, I mean, it makes perfect sense that maybe the Paxlovid was working, and then when it ran its course, the virus took advantage of that. But the original part of the question was, can I get it on standby? And it is only supposed to be written as a prescription for people who are actively infected. Pharmacists are now able to prescribe it, but again, you're only going to be getting that prescription written and filled generally if you are currently having symptoms and tested positive.
Thank you, Dr. Peirce. Levid, a spray manufactured in Israel, is said to reduce the viral load of COVID. It was given EUA there quite a few months ago. Nazidine is under review here. When a preventative is seeing such great results, why is it delayed here in the U.S.?
So again, great question. But the process that we have here in working through FDA approvals is really meant to protect the public. So while we may see great results, and sometimes it may be a very small population, a very distinct population that we see great results. So the protections that the FDA has in place to really take a look at all the data and does it support what it says it's supposed to do before releasing things is really a good process. So I know that they're taking a look at this, and we'll just have to wait and see.
Thanks, Dr. Brown. A recent national briefing mentioned that 105 million doses of the Pfizer vaccine were ordered and are expected to be here in a couple months. Why not Moderna too?
So my understanding is both Pfizer and Moderna did submit data to the FDA on bivalent vaccine, but the real news here is that the FDA on June 30th, I believe, their committee met and said that the BA1 variant is really no longer the active issue. It's the BA4, BA5, and they basically sent them both back to the drawing board to come up with a bivalent vaccine that will protect against BA4 and BA5. My understanding is that has now pushed back the delivery date on a bivalent vaccine to probably November.
Okay. Next question is a fun one. Did I hear correctly that there could be COVID transmission between your cat and the humans in your house?
So I had to look this up. There has been a report apparently from a cat to a human in Thailand. So it's the data does suggest that the veterinarian may have been infected by the cat. But this is isolated. So again, this is one of those areas where we really need to take a look at the case itself and all of the data that supports the case to really be able to say that this truly has happened. I will say in Harris County, as far as I know, David, I don't know if you know anything different. We have not had any instances of household pet transmissions.
Really interesting. So do you guys know of any data for those people who have heard that if you already have a stuffy nose from like a cold or allergies or something, that it can help prevent the COVID virus from getting behind there and you getting infected with COVID? Is that true?
Yeah, so I've not heard that. And quite honestly, I would think that if you already have a stuffy nose, it's going to increase your likelihood because that tissue is inflamed. Now, depending on why it's inflamed, may make a difference, but now you have more surface area because it's now larger, it's ballooned up, so more opportunity for virus to land on it. And once it's in your system, whether it be in your nose or in your throat or in your lungs, once it's in you, it's in you.
Okay, so whether you have COVID or a cold or anything in between, if you're coughing and sneezing, shouldn't you be keeping that mask on no matter what, even if you test negative?
So again, I think Dr. Peirce made a great point earlier when we were talking about the testing. If you have symptoms, you have something. And so the best thing we can do is to quarantine or isolate, keep ourselves away from people as best as possible, because that something can be spread no matter what it is. And if we're going to be out in the public or have a need to do something, then yes, it is best to wear a mask because you have something is the point.
Right, so the San Diego School District has reinstated indoor mask wearing. Any chance that that could be coming back to Texas or Houston in particular?
Yeah, so that's a great question. And let me just start off by saying I really feel for the school boards. Number one, they did a terrific job of trying to navigate an extremely difficult situation over the last 2 years, with parents being very, very firmly feeling one way or the exact opposite on things like masking and in school attendance and so on and so forth. And so as we move forward, I can't imagine that's going to get any easier. And I'm certainly not going to try to speak for nor predict what the school districts are going to do. But I will point out it's a very, very difficult question, and there's a lot of passion. And the science is better today than what we had a few years ago, but it's still not necessarily going to make the decisions that the school boards have to make. It's not going to make it easy.
When it comes to kids, it never is. And speaking of kids, Washington, D.C. schools are requiring children 12 and over to be vaccinated against COVID-19. Any talk or thoughts about a national mandate?
So this is another area where I have not heard, and again, Dr. Peirce, feel free to chime in, that there is discussion about a national mandate. I echo Dr. Peirce's sentiments about those who are in the school profession, everybody in the school profession. It is a very, very difficult job, and it's a very difficult decision to make and balance the social well-being versus the medical well-being of children and of the teachers in the schools. But no, I haven't heard anything about that.
Now, the CDC has stopped reporting COVID levels on cruises. And while we're sure that the COVID industry is really happy about that, is it really the smart choice since we're continuing to see those numbers rise around the world?
Yeah, so the cruise industry, I've never been on a cruise, but I sure do look forward to the day when I can go on a cruise because they sound like a lot of fun. All my friends who've been on cruises say you got to do a cruise. They're so much fun. I have some friends who just do one after another, it seems like. Anyways, but when we've got illnesses that are spreading around the globe, when you have a lot of people and you put them into a condensed space like that, and you keep them there together, you're doing exactly what the virus wants to do in order for it to be able to spread. So, things like cruises are a challenge. On the other hand, again, we are in this awkward time with the pandemic where people are getting infected, but we're seeing less morbidity and mortality. Unfortunately, it's not zero mortality, right? So these are really difficult personal decisions. Right now, I'm not going to go on a cruise. I don't want to get sick. I don't want to get long COVID. I'm fortunately quite healthy, but if I had bad heart disease or if I had lung problems or anything else, I would really think long and hard about going on a cruise just now.
Now, this is a couple of questions that we didn't get to last week. And the first one I think is kind of interesting, and I don't think I've ever thought to even ask this. Do hospitalizations and even possibly death, does that increase the amount of times you've had COVID?
So this is a really controversial topic. And again, this is another one where the jury is out. We're still analyzing the data. But as Dr. Peirce mentioned earlier, every time you get an infection with COVID, you are taking a risk. So the broader answer is yes, there's a risk of hospitalization. There's a risk of death. Does it increase every time you get infected? We're not sure yet whether I think the question is, does the severity of illness increase to the point where you need to be hospitalized and or could potentially die from COVID? We're not 100% sure about that. For the immunocompromised and those who are older, or as David mentioned, have some specific conditions, potentially yes, because it weakens the system.
That's a very good answer, Dr. Brown. Thank you. Another question that we didn't get to last time is, are unvaccinated people more likely to suffer from long COVID than their vaccinated peers?
Yeah, so there are a number of things that do put you at increased risk, and one of them is being unvaccinated, unfortunately. So, once again, to the folks, and we saw this with, particularly in the last wave of the people who are getting admitted and going to the ICU. it was predominantly, almost exclusively unvaccinated, not the current wave, but with the last wave, it was almost exclusively, not exclusive, but almost exclusively unvaccinated folks. And so being unvaccinated puts you at your highest risk for all the complications, whether it be long COVID or hospitalization or death or whatever. So yeah, protect yourself, get vaccinated. Your risk, and let's go to the point of the question. The people who don't want to get vaccinated say there's problems, they don't like this about the vaccine, they don't like that about the vaccine, they don't like the other thing about the vaccine. Okay, you're fine, that's fine. And there's a kernel of truth to each of those. But at the end of the day, your risk of having a bad problem with the vaccine is much, much lower. It may not be zero, but it's way lower than if with the virus. There is not a no risk option here. If you think I'm going to get through all this and never get exposed to the virus, I don't think that's realistic.
I don't think so either. And now we got the new Novavax, so hopefully that will put some of those people on the yes side of getting vaccinated. Next question is, can you reverse neurological damage caused by COVID?
I think this speaks a little bit to the long COVID questions. With appropriate treatments, you can see improvements in many things. It just depends on the symptoms that you end up having. Sometimes we have seen some strokes and things occur. And again, depending on the rehabilitation and the severity of the stroke, I'm not sure reverse is the correct word, but certainly we can improve the outcomes.
Okay, and before we wrap this up, I did have one last question for you, Dr. Brown. On the news yesterday, I noticed that the Harris County Public Health had just revealed a monkeypox hotline. Is there anything that you'd like to talk about that before we go?
Thank you, Morgan. So, and of course, I don't have the phone number right in front of me. Hold on one second. Let me get it. But yes, so we have launched a monkeypox hotline for anybody who has concern that they've been exposed or may be infected with monkeypox. And so this is a 24-hour hotline for our Harris County residents to call. And then we will connect you to one of our epidemiology team to either guide you to the appropriate resources in your local district or to one of our EPIs in Harris County Public Health. And then work through, is there a need for you to be tested? And then also, is there a need for you to be vaccinated if you meet certain criteria? I do have the number. And I do. So the number is 832-927-0707.
All right. And when we edit this, we're going to put that number right there on that screen, and we'll be sharing that on social media. Great resource for monkeypox. But it is time to wrap this edition of COVID-19 Talk with local health authorities up this morning. Thank you again for watching. We want to thank our producers, David Castillo and Priscilla Key, and special thanks to Rotary Club of Houston, past president Kathleen Finnegar. I'm Morgan Ash, in for Director Stephen Williams. Have a great day.